Thank you very much. It's an honor to be here today. I'm going to give you my perspective on the development of a subspecialty of both plastics and orthopedics that several of us from around the country worked on for many years individually and merged it into one where it's come now today. So the first thing you should be thinking is, why is this knuckle-dragging, mouth-breathing orthopedic cretin giving a podium lecture involving plastic surgery? And I thoroughly agree with you on that take on this, and hopefully I can keep your attention up. I went to college at UC Davis. I'm a fourth-generation San Franciscan, and I was going to be a winemaker, and I was serious about it. And one day, I had basic science grants, and the head of the department told me I had to apply to med school. And I said, no, I'm going to be a winemaker. And he didn't argue much back then, so to get him off my back, I applied to med school and got into some. I went to UCLA and slugged it out. I did a senior elective, though, in plastic surgery at UCLA and had the honor of scrubbing and learning from really some world experts, from Henry Kawamoto, the person who really perfected the Lefort fracture stuff with Tessier, Tim Miller, Bert Zarens, Malcolm Lesevoy, and Dr. Tessier was there too, operating about 2 months a year. And I was just enthralled by the stuff I saw and was debating, should I go into plastics? One thing I realized, though, was anything I did in orthopedics, if I was going to be good at it, I had to understand plastic surgery too. And then I heard a talk. The visiting professor, who was the chief of plastics at UCSF, came down to give, I think it was a commencement or something, at UCLA for the plastics department. It was Steve Mathis, and I heard him talk on microsurgery, and he just blew my mind. And I said, wow, this guy is brilliant. I have got to learn this stuff, or at least understand it. I went to UCSF for my residency. And in 1987, I was the last UCSF ortho resident to rotate at Ralph K. Davies Medical Center in San Francisco. And there I met a true god, Harry Bunke. And it was my next life-changing event. Harry was the father of microsurgery. He's been declared that. He founded the American Society of Reconstructive Microsurgery. Harry was one of the most impressive people I've ever met. He forgot more than I'll ever know. For 10 years of my career, I had the pleasure of meeting with him every Thursday afternoon because we had a busy research lab. And I learned so much from him. The guy was absolutely fearless. He was the whole package. I've grown and lived in this area my life, except for when I was at UCLA and at Davis. And it's interesting, this quadrilateral from UCSF down to Stanford, out to Lawrence Livermore Lab, then out to UC Berkeley. When you encompass that, that's the largest number and concentration of Nobel laureates in the world. You can check on it. It's impressive. So I've had the honor of knowing a fair number of Nobel laureates. One of them is still one of my closest friends. They're brilliant. But I will tell you, Harry had it over every single one of them. This guy was the whole thing. He actually was nominated for a Nobel and was declared too clinical, which kind of irks me because that just implies that's not good enough. But the number of people he touched is amazing. He developed the free flap, developed the reimplantation, developed tongue replantation, scalp replantation, all these things. And his group, for years, has still done the most number of replants in North America every year. They were at a high for a while of, I think, 350 during the building boom. They're down to about 225 a year now, which is still significant. Harry, as I like to put it, was the whole enchilada, an amazing person. I then learned about a person in Siberia doing goofy things and regrowing body parts. I said, what the hell? Lengthening limbs, all this stuff? I said, I got to learn about this. So there were three groups of Americans that got to go there. The first group was in 1988. The second group was 1989 in September, and the third group was later in 1989. They then discontinued because it was the Soviet Union. You had to have special visas and everything else. And we had a KGB agent with us traveling. There were 10 in each group. Ilizarov was a brilliant guy. You all know his story about the horse stuff and this, that, and the other. And he was very interesting, kind of a character. This was my group, and you'll recognize people in it. And Jim, you'll see right in the middle there is John Herzenberg. And my boss back then was there too, Lorraine Day. And for all the stuff you hear about Lorraine Day, I will personally tell you, as crazy as she got, she was still the best boss I probably ever had and a great person to work with. And I can only say the kindest things about her. I'm sorry things ended for her the way they did. There's Dan Zenars in that group too from Harbor, UCLA. A lot of the other people in there are dead. It was a while ago. So, point one, the Ilizarov method of bone regeneration was of paramount importance in the merging of these disciplines because the plastic surgeons got it. They said, wow, this is a game changer. When we do bone transplants with microsurgery, they're not as great. And Harry, me, and Steve would talk about that and got very involved in that. The thing that really struck me was this paper that came out in 1988 in JBJS. It was by the head of hand surgery at UCSF at the time, Len Gordon. It was the treatment of infected non-unions and segmental defects of the tibia with staged microvascular muscle transplantation and bone graft. When it came out, the average follow-up of those patients was 2 years. At the time the patient was published, I was a resident at that time at UCSF, and we had cut off about 4 of those 24 legs at that point in time. When the paper was published, it said all 24 did great. And over the next year, we cut off another 4 or 5, and by about 3 years later, half those legs were off. So it was very interesting. I mean, I said, wow, there's something wrong here. This doesn't work, clearly, if half of them are gone by 5 years. And it started bugging me, what's going wrong? And it kept thinking and thinking, and it took me a while to get the answer to this. Be that as it may, I started in practice for UC at UCSF and got to know Steve better after being so impressed with him several years earlier. And Steve and I like this pasture quote, chance favors the prepared mind. I approached Steve with my ideas, and Steve, like Harry, was very open to them and great. And Steve appreciated the power of bone regeneration with combined free tissue transfer, which in 1989, 1990 was considered heresy. It says you can't do that. They'll tear the anastomosis. This is nuts. But a team was born. It consisted of the brilliant one, the scholar, the person with insight, and me. And we got started. And we started doing cases and tried to figure things out. And it was going very well. But at the same time, one of my very best friends, not then, but today, started in a parallel path along the same pathway. And Scott just stepped down his chair at Penn, but he started developing the same ideas, same concepts in parallel, as did George Searney, who was still at Galveston, but was soon moving to Emory. And independently, the 3 of us started on this pathway of how do we combine plastics into everything we do. Scott was trained in plastics too. He was double boarded. George, his wife at the time, was a plastic surgeon and a very good one that had training from Steve Mathis. George was very influenced by this area in that he heard about a crazy guy at Kaiser who was treating osteomyelitis with infection. And George was trained as a tumor surgeon. He was trained by Bill Enneking. So Enneking told him about this guy who was his closest friend, and George actually came to Oakland and spent a few weeks with JOJ, which is very interesting. And that was a huge influence in George's life. So, an early case from early 1990s. Here's a guy, 25 years old, isolated grade 3 open right distal tibia and fibula fracture. This is it. Not the worst you've ever seen, but how do you treat it? Well, there are a lot of ways to do it, but I can show you the one way I would never have done it back then, 1993. He was treated by a surgeon who saw an ad for the JBJS for an Ilizarov fixator and took the guy to the OR and acutely shortened this kid 8 centimeters, did a partial fibulectomy and proximal tibial corticotomy, all done initially at the initial setting. And this is what it looked like. He was very proud of himself, as was the resident with him. However, nothing ruins good results like follow-up. And over time, the leg started to circumferentially slough. The soft tissue envelope just died around it, circumferentially. And it died more and more and more. And the kid was a dental student at UCSF. The family started taking pictures of the leg. And there it is, tibia that used to be alive. And that's all candida now growing on this bone that was killed. So now you're getting more and more dead tissue. So at this point, they said, okay, this isn't going well. Had a sensate foot. They scheduled him for a baloney amputation. Family refused. UCSF got involved. And he was transferred to me. And I looked at him and said, wow, I think this is a good candidate to try some of these things on early. We'd done a few, but not for something this large a defect, because he was shortened to 8 centimeters, 7.5 centimeters of prior excised bone, 15.5 centimeter defect near circumferential soft tissue loss with a foot that worked. So when I first started doing these, we one-staged all of them. Here's the latissimus coming down to the leg with just a little simple spanning device. It's over it. Re-explored the corticotomy. It wasn't a corticotomy. It was an explosionotomy of sorts that I couldn't figure out. And just started pushing on it and sitting back. So what we started doing first, train going down the tracks. We're moving that ring down and growing bone above. When we get to it where it's docked, we then start lengthening the limb. Lengthen the limb. Gave him his 15.5 centimeters back. Limbs are of equal length. That's what his leg looked like when we were done. Long treatment plan, don't get me wrong. This kid's in his 20s. That's what the leg looked 6 months after frame removal. Here's him clinically in our clinic at UCSF, 7 months after the frame was removed. He went back to dental school. He completed dental school. He practiced as a dentist in Las Vegas, I believe. And this is him at 25 years. He retired, moved to Reno, skis for recreation, had another child. And this is what he sent me, a 30-year follow-up. This was sent to me, he emailed to me like 6 weeks ago. He made this, wanted me to have it. That I'm not very good at amputations, but I can tell you, I don't think an amputation will allow him to do that and lead a normal life. So this thing, I started appreciating more and more, as did the plastic surgeons I work with, how powerful this tool can be. It was just a matter of how do we use it best. So we started publishing on it, and this was, I think, the first big paper in the literature on it, 36 cases of this, done with Isa Eshima, who's a plastic surgeon with Steve, and Steve as well. And we looked at our results. They were coming out pretty good. So we brought in the infectious disease docs, started training them and teaching infectious disease docs about this. Back then at UC, I had a psychologist that worked with me on all those. I wish I could have that again. It was the most invaluable part of my treatment armamentarium. He could squeak out the crazy people and knew how to deal with the ones that weren't crazy. And it became very apparent that this orthoplastics combination would be really useful in cases of infection and care. And Steve's insight was so clear. I actually had a joint appointment in plastic surgery. So every plastic surgery resident, they were fellows then. It wasn't a residency, it was a fellowship, would rotate with me. And actually, up until now at Stanford, every plastic surgery resident in our R3 year spends 2 months with me. Actually, some a little more, to learn about infection and what to do. I wish the orthopedic surgery programs around the country required R3s or R4s to spend a little time on plastics. I think it would be very valuable for all of us in the future to understand it better. Then I met George, and George was the next game changer in my life. George, I really consider the father of modern-day osteomyelitis surgery. No one will ever do what George did. George could show results and outcome for 3,200 cases of osteomyelitis. That's a crazy number. No one's going to be able to do that again. It's just not possible. Plus, it's a litmus test for mental insanity, quite frankly. But he loved it. Amazing guy. He did it with John Motter, who developed the classification with him. John was an infectious disease doc, a brilliant one. Unfortunately, John passed before George. He had bipolar disorder and went off his meds and had a bad outcome. George is the person who coined the term living wound. He deserves all the credit. What he proposed, and which is absolutely true, is through methods of soft tissue management, not bone, soft tissue management, you need a wound that's alive. And he described it in a multitude of ways. But this is a key concept that I live by today. The classification system, there are many out there for different things. This is the one I can remember the best because it actually dictates treatment care. That's an important concept. There's the usefulness of it. So I think anyone who's going to treat a bone infection is obligated to at least try to differentiate what type it is, as it will guide them in their treatment. And it's all too often that the 9 out of 10 times patients I see sent in to me have never been classified. And it's this obscure treatment of a hodgepodge of things with no game plan. There's a protocol for every one of these patients for us, and it's been that way for at least 25 years, and it works. I'll show you that. This is the relationship of the CM stage to what treatment you do in general, and it's really quite correct. Infectious disease docs, everyone bitches about them and says, oh, the infectious disease doc, they're my problem, this, that, and the other. For me, it's exactly the opposite. I've worked with them very closely through my career. I've trained a fair number, where I'm at now, for them to do osteomyelitis, they have to have been trained by me for 6 months first, and then they do it. My best one, she left to become head of musculoskeletal ID at the Mayo Clinic, where she's brought the ideas to the Mayo Clinic. My biggest proponents of not using antibiotics on these patients are my ID docs. They get it. It's exactly the opposite of what everyone else I bet in this room experiences. It's because they understand the disease process. They see patients with me in clinic at each visit. We're therefore on the same page. I urge you to do this. I'll show you our results coming up. And I think the problem has been us, not them, and that we failed to educate them properly. And if we do, we'd have a much easier time and a much better outcome for our patients. Why does all this matter? The CDC and the London School of Epidemiology and Tropical Medicine have both projected that the leading cause of death in the world by the year 2050 will be death due to antimicrobial resistance, specifically multi-drug resistant organisms. That's two big, famous, independent organizations saying the same thing. This is scary. We got to watch what we're doing. In the US currently, we consume 51 tons of powdered antibiotic per day. Now, 70% of this is in agriculture and farm. However, 30% in humans. Our method is not working. We're killing ourselves. We have to try something different. So, the infection issue is not going away, and if anything, at least for the short term, the problem will get worse. Musculoskeletal infection has to be a subspecialty of infectious disease. The regular ID docs have never learned it. It's not their fault. We have to push for this to improve the quality of care for our patients. Once we were doing all this, we started looking back and saying, you know, we're saving these limbs. Is this good or bad? Are we really helping people, or are we just fooling ourselves? So myself and the members of the Bunkie group decided to look at it. And we took people that were sent to me to have an amputation. At least one member of one of their orthopedists said, you need an amputation. We'd see them. And instead, we treated them with a bone transport and free flap reconstruction. We wanted to see if it really would work or not. And 34 patients, here's their demographics. 35 flaps and 34 patients. One had a partial death as well. Mean defect of 8.5, say, centimeters, 8.5 to 9. Fixator time, around 11 months. But the key thing we wanted to do is get long-term follow-up. Because the problem is, remember, the Len Gordon paper, 18 or 20 months follow-up, I needed years, over 10 years. This is 11-year follow-up, mean and median, with a range of 6 to 18 years, to look at these people and see what really happened. And in fact, of those, none went on to an amputation. 29% required some type of reoperation, okay? 97% went back to unassisted ambulation. One required an assistive device. Pain medications, 2 were on chronic pain medications of some sort in the form of Vicodin. Return to work, good number, pretty high, really. Goes against a lot of the other studies out there. If you look at costs now, because that's what we were interested in as well, are we just blowing money for the government or insurers? We use the LEAP study as a basis, and in the LEAP study, they put the cost of a BK prosthesis at $7,700. Good luck. Little low, I would say. For a Thruni at $16,000, not even close, but we'll take it. We're going to use those numbers. We're going to use what the CMS has decided is the acceptable charge. And AKA 18.7, I saw one recently, the price tag was 75 plus. So those days of that number are over. And the paper by Chung, looking at this and going by the CMS guidelines, says that after 2 years, an amputee has an average cost for prostheses and other care of $410,000 over the rest of their lifetime. And it's probably realistic. It's probably more, to be honest, but we did a cost analysis of our group, and at 2 years after, the cost became about $1,000 a year per patient, and it went down with time. Comparison of costs. 11 times cheaper to preserve a limb if done correctly over the lifetime of a patient in a group of 34 patients as compared to CMS guidelines for cost. Here's the reintervention rate at 2 years. It really flattens out on the Kaplan-Meier curves. So if you get it right, you get them walking, you get them on with their life, you get them off drugs, you tell them they're going back to work and you're going to get a life and they're not going to be disabled forever, you can actually make these people better and save money significantly for society. So we said, well, it's okay for us to keep doing this. So we started looking at, and this is Mike Giddens was my resident at the time. Mike's one of the attendings up at Harborview now. And we looked at 128 patients with the combined procedure to see how they were doing. And really, by that point in time, 3 underwent amputations. That's 2.5%, give or take. We thought it was a safe and effective procedure. I think I've completed about 166 cases to date of these. So it's a moderate number. I was more interested then in how does this affect infection, because infection is going to come to haunt us. So Gina Suh, who's the head of musculoskeletal ID now at the Mayo, one of my ex-residents, Malcolm DeBon, who's one of the orthopedic traumatologists at Duke now, I put this together of 127 consecutive cases of chronic osteo. Here's the breakdown for their stages, like in the previous hands-on workshop I showed you. The majority are Cerny Motter stage 3s. Host type, this is the big deal. For me, the host matters more than anything. The type of bug, I could care less. I don't care what the bug is. It doesn't make a difference in my outcome. Most were type 2 local with some type of local problem. Very few were perfect, only 17%. Sites on the body, it's everywhere. I do now way more pelvic osteo than we just have a huge influx of it for a complex reason, which I can tell you later. My treatment algorithm has not changed one iota. It's stayed exactly the same for at least 30 years. You have to go down the ladder. You can skip a step if it doesn't need it, but you can't ignore it. It's simple. Get everything dead out. Manage the dead space. Get a healed soft tissue envelope. And what's the last thing in the procedure? Reconstruct the bone defect. The bone is the least important part in the formula. Exactly opposite of what we would think as orthopedic surgeons, right? We're wrong. It's the soft tissue, it's everything else, how you handle it. Liberal use of free tissue transfers. You look at me wrong, you're going to get one. So 5% of patients received greater than 5 days of antibiotics. These patients were immunosuppressed from cancer, from bad rheumatoid disease, from lupus, things like that. Otherwise, none of them got it. They got 2 or 3 days of IV antibiotics and maybe a week of orals. That's it. Nothing else. George had done this before on 400 people in each treatment arm of 2 weeks of IV antibiotics versus 6 weeks or more. And the results were a little better in the shorter duration. He could never get it published. When he was dying, he tried to get me all the data, but he missed some. Doreen, his wife, then tried, she got very sick, and she was dead 6 months later. And I promised him I'd get it published. Bruce Browner said he'd publish it in Techniques in Orthopedics. No questions asked. I could not get all the data complete, and I failed him. But his data backs this up, too. You don't need the IV antibiotics. They're poisons. I urge you not to use them so much. And it's really about the orthoplastic combination of seeing things in the soft tissue and bone eyes together and treating the person as a whole. IV antibiotics are superfluous, to be honest. That's our rate at 3 years of cure, and that one patient that was added is equivocal. He looked swollen, red. I'm calling him a failure, but I went back in and nothing cultured, but I'm listing him as possible failure. He's cured, he's 8 years out. So the real problem is the breakdown in my practice. Since half non-unions are infected, that means 2 out of every 3 patients I see has bone infection, which is another litmus test for mental insanity. But it's worked out so far. So everything I tell you is going to be biased, of course. Here's an example of how we can use plastics and ortho together. And I can show you case after case after case after case, but I don't want to do that. I want to pick out some different ones. This is a young guy, ATV rollover, crushed leg, no palpable distal pulses, with a cold ischemic non-sensate plantar surface of the foot, who's hemodynamically stable. It's the only injury he has. He's in perfect health. The resident showed me these pictures, and I told them the outcome before I ever met the patient. You see the staples up high. Then you don't see anything. Then if we had on the contralateral leg, that's the saphenous vein being harvested. But on the ipsilateral leg, if you go further, there's then some staples by the ankle. And I said, got it. He's going to get worse. That's exactly what happens. That's your sign. Remember, vascular surgeons, they know how to do one more operation than I do, 4. And those 4 operations, one of them is a fem distal bypass. Community hospital does what he's comfortable with, fem distal. What happens? It's absolutely predictable. They had fixed high, they'd bridged, and his limbs just started dying circumferentially. It's a Steele effect. You're taking the blood flow and you're robbing it all the way down south and restoring it back at the ankle. Everything in between wants to die except for collaterals. So watch out. Why do we have to know all this stuff? Because we have to guide our vascular surgeons, we have to guide our plastic surgeons on the right treatment, because we should be the most educated people in that room when we're making decisions. So now we got a problem. This wasn't so bad, now it's bad. It's a big hole, big bunch of dead stuff. Obviously, what is it? It's a 4. Save the fibula whenever you can, it's your friend. I do it with something simple usually, just to keep some integrity to it. And we chopped till there was living bone again. When we found living bone, we stopped. I know no better way than looking at it. I have no better test. And he got a latissimus free flap. And again, I mentioned in one of the sessions this morning, latissimus are really finicky, and I'll tell you why. When you flap them, you cannot stretch them. It's the only muscle flap I know of. If you put a little stretch on it, the distal third will die. Unfortunately, in the last 15 years, I've had 2 partial flap deaths in all the people I've treated, and both were latissimus distally, and this is one of them. He died distally by a very good plastic surgeon. Distal third died. Now we're seeing exposed bone again. So this is a problem. What are you going to do? Flap below a flap? You could. We've done that. It does work. The patient refused it. I don't blame him. So how can you save this thing now? It's a real problem. It's an operation, God, I think I'd end up, when I count, doing it once every 7 years. I think if I ever go above that, I think I'll shoot myself. I got to take Zofran before I do it each time because it makes me so sick to look at. It's not acute shortening. It's an angulatory deformity closing. So you take that leg, put it in something like a spatial frame or whatever you want, and you slowly bend it to close the defect. Let it get closed. Skin graft, everything else heal, and just sit there. Don't do a thing. Just ignore it. Let the soft tissue envelope heal. Remember, you got to go down the chain. Soft tissue comes before bone. So, I mean, when I look at that, I have trouble walking out of the OR. I feel guilty. Here he is. That's gruesome. You slowly start stretching it. Starts getting straighter and straighter. Got a straight leg with a healed soft tissue envelope. Bone transport. Gets a bone transport. And I made a technical mistake on this. I left a tip on it because it was an 18 centimeter transport, and I was trying to not have to get too crazy, but you know, to get in those bigger numbers, it gets a little more tricky. So here he is at frame removal, and I'm sitting on a spike, knowing I'm going to have to do something later. I just told him, take it easy, we'll bone graft you later. And he's pretty happy. His leg looks pretty good. I told him not to walk, and then at the 6-week mark, you get 4-week mark, 6-week mark, I'm sorry, because it was 4 weeks later, you get the call. I slipped in the shower. Remember, trauma is a disease. So he comes in, and he's broke it there. It's not the end of the world. We can deal with that. Put him in a cast, let him wait. Go back to the basics. 2.5, 3 months late, dropped a rod in him. Here he is, 17 weeks, 1 year, 2 years, 6 years. He owns a car detail business. He works full time, does fine, likes his job. Here he is. That's an ad for his car detail. If you need a car detail in the area, call Integrity, please. No. And he went on with life. He's doing fine. I hear from him once a year. The strength of the combined procedure, it's real. It's understanding plastics and ortho and having a bunch of stuff in your armamentarium to deal with it. Here's a very old case I want to show, just to show you some weird extremes. This is a patient, the resident with me when we did this case was Sean Norick. I'll never forget it, because he thought I was completely mental at the time. 60-year-old female with diabetes, had a tibial plateau fracture repaired in Central America for 4 years prior. Came to California and started working her way up the coast, first UCSD, then USC, then UCLA, then Stanford, then UCSF, and came in there. And I remember the doc who saw him was one of my partners, Bob Namba, who looked at this and said, nothing I can do. But he goes, I got this goofy partner, he'll do anything. So he sent him to me. And everyone told her she needed an AKA. So Sean and I look at this, and in fact, every time she took a step like this, pus would shoot out through the hole. A little tasteless, but very nice lady, kind of round. But that's all dead. It's all dead. What we had to do is clean it up. Cleaned it up, and we took out her entire proximal tibia, just threw it in the garbage, and put some suture around the patellar tendon, a wire, above the patellar tendon, held it the patella in place. And put her in a frame and started doing a transport. I think we did this in 94 or 95. It was a while ago. And moved her up. So I'm going from south to north. And once we got up high, you can see that wire holding the patella in place. I then cracked the leg front to back and put cross wires in and started growing the bone out, because we were going for the home run here. We weren't going to quit at something simple. And grew a tibial plateau back for her. So now we had a little tibial plateau we could probably work with, and eventually got the frame off. This year's, what's this, 94, does that say there, I think? Yeah, 1994. I took the frame off too early. She cracked a little below, but it healed. That one's on me. And figured, okay, let her wait 6 months. And I called Bob Namba up, and I go, hey, tag, you're it again. And Bob put a total in her. And she went on with her life. And I had 4-year follow-up on her. She was walking independently without pain, didn't want to come back, lived in the Salinas area, no infection, taking no pain meds. Oh, we had done, the reason I bring this into, we had done a gastroc rotational flap for plastics coverage of that. Plastics helps with that part. Again, plastics, ortho together, you gotta combine them. Don't be afraid and do what you gotta do. And find the best microsurgeon you can find and buy them a great Christmas present every year, I do. And it works, because you need them. They're invaluable. This is one in a different field. And truly, I think this is the best example of this slide that I have. And unfortunately, it involves sports medicine, a 17-year-old with an ACL tear. Common injury, right? Why orthoplastics is important is it does not spare any field of orthopedics, hand, shoulder, elbow, spine, I don't care. One of the attendees today is a spine surgeon, asked me questions about dealing with the spine. Everyone's going to get infections, every field of ortho. Therefore, we're obligated to at least understand this and know this. Common injury, common mechanism of action, had a patellar tendon bone reconstruction in 2001, went back to playing football early, retore the ACL, underwent autologous hamstring reconstruction in 2002, and MRSA with septic arthritis. Infection just kept continuing. He moved to Boulder to go to college, went to college in Boulder, recurrent infection in 2004 at the tibial tunnel and screw site. They debrided that. Developed recurrent lateral thigh abscesses in 2005 and 2006. All between this time, he's getting bombarded with antibiotics. Bombarded. PICC lines right and left, on and on and on. See how well they work? Didn't cure a thing. Developed a recurrent medial distal femoral sinus tract after a while. Underwent debridement of this in October of 2006. Recurrent medial femoral sinus tract. February 2007, sent to the head of orthopedic oncology at University of Colorado, who said, I got it. This is what we're going to do. Did this. Filled the entire distal femur just about with bone cement, with tobramycin or something, who knows, in it, and said, you're cured. And he was absolutely cured for 6 weeks. Went on 12 weeks of IV antibiotics now. 2007, recurrent medial thigh sinus tract, breaking through now on IV daptomycin. I don't know how many PICC lines he had had. See how well the antibiotics are taking care of this. This is him. He got scheduled then for above knee amputation. He's 20-something. Terrible, right? So I get a call from an ID doc, says, would you just look at him? I go, yeah, sure. And it was like 4 days before the AKA. And I look at him and I go, oh, God. Here's a CT. You see something there? See that dot at the tibial tunnel? I mean the femoral tunnel side. That trough there, that soft tissue glob with that little hole there. There's a ring sequestrum there, and that's where the osteo is. It never got addressed. Took him to the OR. Dead space management. Had to take all the cement out at the same time. Problem is, you got to backfill. You can't graft that acutely, so my high-dose antibiotic bead concoction got him sterile. Then you start the reconstruction. I like cancellous autograft at the epiphyseal or metaphyseal regions to restore a normal spongy bone in young, healthy people especially, proper load transmission, whole bunch of reasons I can go into you with basic science background on it, why that matters in the long run. And then once we get that healed, you can go back to the diaphyseal segment and bone marrow aspirate concentrate, whatever you want to use, crushed cancellous allograft, pick your poison, whatever. At the diaphyseal segment, it matters less. Here he is 9 months after final grafting. He's asymptomatic. 2 years. 9 years, he's infection-free, no limitations, able to run, occasional knee pain. Here's the way his leg looks. And he's done well. Very good. Tough problem, but we can save him. No plastics involved in this. But my point of this is every field of ortho, you should know this stuff because you're going to get hit at some time or another. The only way you're not going to deal with this is if you don't operate. It's just impossible not to. We tried to, we have this as protocols, and it's written up if you want to see it. I wrote it up with Ian Sabursky, who's the head of microsurgery at Walter Reed. He was a Bunky fellow with me, great guy, fantastic surgeon. And Dave Chullock, who's one of our residents in plastics. And it's a really algorithmic approach to all these and how we approach it and how it does. Published a year and a half ago. I can't stress enough how important Scott Levin's been to this. He was really the guy who took the bull by the horns and started a journal, Orthoplastics, which is really a spectacular journal. It's just getting its feet off the ground, and it's doing just fine. He's the editor-in-chief. And Scott is my brother for life. He was just out here, spent a week, him and his wife, with me, and a brilliant person, a very insightful doctor, and been a good chairman. If I have to pick the 3 game changers in limb salvage in the last 40 years, it's specifically 3 things. Microvascular free tissue transfer has been a game changer. No way around it. It is one of the most powerful tools I've ever seen. However, it will fail if not done correctly. If you flap over dead bone, it's going to fail. It's a disaster. So it takes the proper orthopedic procedure to make the plastic procedure work. It has to go hand in hand. Bone transport, the Lazaroff method, strong tool. It works. Just a matter of getting used to it, knowing how to do it, and perfecting it. And a clear understanding of biofilm and chronic osteomyelitis. Infection still remains the primary reason for many of these procedures having to be done. I get it. You have to combine all knowledge in all 3 of these to really get your best result. I think it should be regionalized to some extent because it does require a team. It does require not just plastic surgeons, but infectious disease docs who get it as well. It's not easy. Therefore, I tried 5 days ago to define orthoplastics. And the way I define it is a culture where the orthopedist fully understands the indications, nuances, and values of soft tissue plastic surgical procedures, and the plastic surgeon understands the indications, methods, and values of the bone and accompanying joint procedures for limb reconstruction. This then becomes a subspecialty intermingled between each of the services. I'd like to thank those before me who've influenced me the most. Robert Gordon, who got me to go into orthopedic surgery, Harry Bunke, a god, George Searney, Steve Mathis, a local orthopedist, Lionel Sines, who was just an incredible surgeon. My first partner at the VA, he brought me on there, Dick Maurer, who was a prince of a guy, and Bill Murray, my chair, who sure was good to me, and someone I shared an office with for 5 years, J.O.J., who was a kick and a lot of fun. Lorraine, of course, and Mike Chapman, he's in Grings. He's the only one still alive. Mike's fighting a bad illness now, and I'll say a prayer for him, and God bless him. Thank you.